Next presenter is Dr. Kiran Chandran. His paper is on characterizing right angle vessel to study its role in mactal progression using multimodal imaging.
Good afternoon. Today I'll be talking on characterizing right angle vessels to study its role in mactal progression using multimodal imaging. So right angle vessels have been defined as per the Gasson-Bloody clinical staging into stage 3 mactal. Recently, a lot of interest has gone into using multimodal imaging, specifically OCTA, in characterizing the vascular changes in mactal. And Saradis and colleagues published a paper in BJO in 2021 where they studied characteristics of RAV in mactal and its relevance with mactal-associated neovascularization. So they studied RAVs as early as in stages 1 and 2 and associated disease progression associated with RAV. And even morphological changes in RAV precede neovascularization in the form of dilatation, elongation, and apparent discontinuation of the vessels and occurrence of pigment plaques. So RAV is defined clinically as per the Gasson-Bloody staging as follows. They appear as vessels with a dilated and more prominent appearance and which bends at a sharp right angle into the deeper retinal layers. So the quadrant-wise classification of RAV was done by placing an ETDRS grid into the center of the fovea and dividing it into 8 broad divisions using ETDRS subfields. So aim of our study was to determine RAV associated changes on SD, OCT and OCT angiography and to follow up cases of RAV to determine its role in disease progression as well as to study RAV associated morphological changes during the disease course. This was a single center observational study recruiting 56 eyes of 49 patients with RAV detected clinically and confirmed on multimodal imaging. So in this diagram, you can see vessels which appear as an RAV, but they are not very definitive. So using a reference standard that is whole retina slab of the OCTA, which is an amalgamation of different slabs of an OCTA, you can see an RAV which is demonstrated very well on a whole retina slab, which may be missed clinically. So using multimodal imaging is important in diagnosing the presence of RAV. So the following parameters were studied using OCT, that is outer retinal defects in the form of attenuation, where there is no obvious loss of any layers, but there is patchy loss. Then coming to loss of IDZ and EZ and loss of external limiting membrane. Then collapse of the inner into outer retina, inner and outer retinal cavitations, pigment migration, outer retinal hyperreflectivity. On OCTA, we studied the different plexuses like superficial vascular complex and deep capillary plexus are studied for the presence of telangiectasias as well as foveal avascular zone changes. In the outer retina choriocapillary layers, the presence of nodular hyperreflectivity networks as well as retinal coronal anastomosis was studied for. So 49 eyes of 56 patients, 56 eyes of 49 patients were recruited and at least 3 follow-up visits were done with a mean follow-up duration of 20 to 52 months and majority of eyes had stage 3 disease followed by stage 4 and stage 5. So as you can see in this table, majority of the OCT findings had a direct correlation to the presence of RAV. All outer retinal changes ranging from IDZ, EZ and external limiting membrane had an associated RAV to it. Followed by retinal pigment epithelial migration as well as outer retinal hyperreflectivity. So the most common associated RAV finding was with IDZ loss as well as EZ loss. Even in follow-up parameters, at each quadrant where the RAV was present, there was progressive increase in the extent of loss of IDZ, EZ and ELM as demonstrated in this table. In OCTA, RAV demonstrated telangiectasias in the DCP in all patients and telangiectasias were typically located in the temporal quadrants in OCTA and vascular invasion involving the foveal vascular zone was seen in 4 and 6 eyes in SVC and DCP respectively. The presence of nodular hyperreflectivity, network and RCA was seen in 4, 6 and 3 eyes respectively. So coming to a few examples, this diagram demonstrates the RAV associated interdigitation zone progression in mactal. On multicolor photo, you can see the presence of RAV temporally. On whole retina slab of OCTA, this RAV is appearing very prominent and corresponding deep capillary plexus shows telangiectasias which appear as slightly dilated and irregular vessels adjacent to the foveal vascular zone. At presentation, the OCT does not show much IDZ changes. This is called IDZ at risk, which appears as a serrated appearance of IDZ. And on follow-up 1 and follow-up 2, you can see the IDZ is attenuated followed by complete loss of the IDZ at the final year follow-up. This is an example which shows a detailed 10-year follow-up showing RAV associated changes in mactal. using fundus autofluorescence and OCT. At initial visit, there is no changes on OCT, it appears normal. When the RAV appears, there is IDZ loss happening with subsequent increase in the EZ loss and pigmentation, which initially is non-central, which progresses to involve central fovea as well. So over here you can see a blue reflectance image showing an RAV superiotemporally, and exactly where the RAV is dipping into the deeper retinal layers, you can see the outer retina shows changes in the form of outer retinal hyperreflectivity with ellipsoid zone loss. As we progress into the disease stage over subsequent follow-ups, you can see the EZ loss is increasing and outer retinal hyperreflectivity is also increasing. And the corresponding octa slabs in subsequent follow-up visits shows increase in the nodular hyperreflectivity to form what appears as an irregular reflectivity, but almost looks like a network forming. So this example demonstrates the formation of retinochoroidal anastomosis in Mactel. Over here, there's a choroidal neovascular membrane, subretinal neovascular membrane in multicolor photo, and SD-OCT shows the presence of outer retinal hyperreflectivity. The corresponding whole retina slab shows the presence of two right angle vessels with a anastomotic complex being formed with the underlying choriocapillaries. On outer retina choriocapillary slab, you can demonstrate the presence of a well-defined circular network. Even morphological changes in the form of vessel straightening, as you can see in whole retina slab, is demonstrated over a 4-year follow-up, with subsequent DCP showing lateral elongation of the foveal avascular zone as the disease progresses, and outer retina choriocapillary shows the formation of a well-defined vascular prominence as we progress towards the disease course. This example again demonstrates using a fundus autofluorescence that the right angle vessel, which was initially dipping inferiorly, shows a sharp deflection as a right angle towards a neovascular lesion, and corresponding OCT shows the presence of outer retinal hyperreflectivity and increase in the ellipsoid zone loss. So what was known before was that RAV was associated with disease progression and contributed to the development of neovascularization in Mactel, but this study adds earliest changes in the outer retinal layers are directly linked to RAV, and even telangiectasis formation on octa are related to the formation of RAV. So RAV is associated with progressive increase in the loss of all outer retinal bands, and thereby suggesting that RAV can serve as an important biomarker in Mactel right from the early stages of disease. Thank you.
Very nice study. So my question is that, do you think that those who are not having the octa, they won't be able to pick up all these things, and or in other way, is it mandatory to do octa in all such patients?
So RAV was initially diagnosed clinically, but recent multimodal imaging, especially blue reflectance imaging and multicolor photo, are also extremely sensitive in picking up an RAV, especially the green reflectance as well as the blue reflectance lab. And even FFA was initially the gold standard for diagnosing the RAV, but FFA changes get obscured once the leakage etc. happens. So octa is being employed because it's easy to do an octa and you don't miss out on subtle findings such as an RAV in following up patients.
There is no doubt about the role of octa because it's already known.
True.
So what I'm trying to say is those who are not having access to octa, so how they should do, what is your recommendation?
An OCT can be done, and so for example, these biomarkers which I suggested in progressing, showing the follow-up of Mactel, they can be followed up. And even a cursory examination, we may miss out an RAV. So you can keep a close watch on the morphological changes that develop an RAV. Even a subtle fundus autofluorescence can help actually in picking up an RAV. Yeah.
What about a simple fundus photograph with the high zoom?
Yeah, the 30-degree view definitely helps, and the recent photo I showed where they are. That is a 30-degree. Yes, sir. You can use the fundus photo with 30-degree view where you can pick up RAVs. True. Yes, sir. Sure.